day, and welcome to Epstein, Becker, Green, and EBG Advisors webinar, Analyzing Trends in Utilization Management, a focus on regulations, part of the Thought Leaders and Population Health webinar series. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are welcome to submit questions throughout the program by using the Q&A feature provided by WebEx, and at the end of the program, with time permitting, the speakers will address your questions. You are also welcome to submit questions directly to the presenters following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein, Becker, Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We hope you join us for our upcoming webinars. For additional details, to register for an upcoming webinar, or to find recordings of prior webinars, please visit www.ebgadvisors.com. Our next Population Health webinar will be September 21st, covering topics of relevance to safety net healthcare providers. We're pleased to have 3 fantastic speakers today. EBG Advisors Bob Atlas, who is a strategic advisor and president of EBG Advisors, Inc., Sherry Latimer, Executive Director at Case Management Society of America, and Gary Carneal, President and CEO of Schooner Strategies, as well as Senior Policy Advisor at the Kennedy Forum. At this time, I'd like to turn the webinar over to Bob Atlas.
Hello, everybody. Good day. I'm going to be brief, and because we have a lot of content and excellent speakers to bring you that content today, I just want to introduce this topic by noting that utilization management as a term has been around for a long time. You may recall that last week Medicare and Medicaid turned 50. Utilization management is only slightly younger, and perhaps that's not a coincidence. Plenty of folks over the years have repeatedly tried to declare dead. Usually, they say the need is obviated by things like delegated risk arrangements or pay for performance, but it persists nonetheless. In fact, I'd argue is making a resurgence, and the web of regulation around utilization management is growing ever more complex. I'll give you just one example from personal experience. Right now, I'm working with a team to implement national health insurance in a Caribbean nation. And is one of the pivotal elements of program management, along with wellness programs, quality management, and other measures to ensure the effectiveness of the whole healthcare program. I might also note that we have several hundred participants in today's call. That's very telling. So without any further ado, let me turn the microphone over first to Sherry Latimer, and I'll be back in a while to help make sure all your questions get answered. Sherry?
Thank you so very much, Bob. I really appreciate it, and thanks to everyone for joining us today. You know, as Bob was talking, the slide, as it says, the rise of utilization management has been over a significant amount of years. And as we think back about it in the 80s when we were first seeing a lot of the issues and focus around utilization review, there were many things that both providers and professionals that were working in this field were really trying to understand and how to deliver those services. I remember that very vividly. I was actually in utilization review and management in the late 80s. As we moved towards the 90s, we saw more legislation around and regulatory guidance around utilization management. We also saw the emergence of standards that URAC brought forward about independent accreditation, about utilization management, and about the workflow and the processes. In between that 80s and 90s, and as we were moving forward, well, I'm sure that a lot of us that have been in this industry for that amount of time remember that there were all types of discussions about, well, what type of criteria are you using? What is it that you're looking for? What is the focus of the medical necessity review, the length of stay, or the pre-cert? What type of criteria is being used? And as we move towards accreditation standards, we were able to standardize some of that and really focus on how do we provide that service, what does that service mean, and what are both the professionals on the side of delivering utilization management and the providers that we're working within that system needed to understand. It has continued to mature as we went into 2000, really looking at how do we integrate that process with the full system of medical management, understanding not only the medical necessity determinations, but how do we use that as we look at care coordination and the focus of those particular services. As we saw the Affordable Care Act come in, it became even more evident of how this process needed to work with and be part of the care coordination process of changing our delivery system and delivering a better care. I go back to when we first started this whole process, it felt like we looked at almost everything, every single admission that went into the hospital, every single procedure that we were looking at. It was a constant focus on this process. And the denials were pretty extensive, not only because it didn't always meet criteria, but because providers didn't really know how to interface in doing these reviews and the criteria that they were being held to. We've matured significantly with standardizations, not only having regulatory accreditation standards, but regulations across our various states about this, and how to move forward and how to put that into place to really be able to improve that documentation around the utilization of services and where it needs to be delivered. As we look at that next slide, we're really talking about how do we define not just the term utilization management, but many of the other interventions that we see in the care coordination of delivering both care, services, and the process across that continuum of care. If we think about utilization management, and I think one key thing I'd like to point out here, and hopefully all of you that are listening to this process will go, yes, I understand that. Almost each one of these terms has some different twist of definition depending on who we're talking to. The consistency of how we apply these terms and how we address what they deliver is not always clear-cut. In some cases, some things are used interchangeably. But I want to try and define each one as we see the industries and the standards that are being developed around these to try and clarify that in delivering care coordination, which to me is this larger umbrella of how we work with our patients and their family caregivers and our providers through this, all of these services may come into play. So if we think about utilization management and look at it as the evaluation of medical necessity and appropriateness and the efficiency of the use of healthcare services, procedures, and facilities under the provision of applicable healthcare benefits, that's sometimes called utilization review. But utilization management expands that into also the coordination of those services across various aspects. Remember that within we have various deliverables that are part of that process. We have the pre-cert or the prospective review. We have concurrent review, length of stay, discharge planning review, retrospective review, second opinion review, pharmacy review, and often we look at it also, as we're going to talk about our last piece, independent review. So all of those various factions are part of this program. The healthcare professionals that are involved in utilization management have the responsibility of being able to balance the quality and the risk and the cost concerns. And the goal of should be to maintain that quality and efficiency of healthcare delivery by making sure that we treat our patients at the appropriate level of care, that we're coordinating all of the available healthcare benefits, and we're ensuring the least costly but the most effective treatment plan. When we look at it from the standpoint of case management, and we look at the definition that the Case Management Society of America brings forward, which is also built in accreditation standards, both by URAC and NCQA, and Joint Commission points to that, case management is the collaborative process of both assessment, planning, facilitation, care coordination, evaluation, and advocacy for options and services that meet the individual's and the family caregiver's comprehensive health care needs through the communication and the available resources to promote quality and effective care and outcomes. More individualized at the patient and that family level, and constantly looking and helping through the advocacy role and delivering those services. Disease management, as we've looked at that over the years as it's been developed, and actually started in the 1980s also, is a system of coordinating that health care interventions and communication, and in its early years was really focused on a specific population or chronic condition. Many of us remember that the DM disease management programs that were delivered were for asthma, for COPD, for heart failure, for diabetes, each one working on with the patient around self-care efforts and the identification of symptoms and how to help work through that in addressing those issues. Disease management has really moved and evolved from an individual disease state to treating multiple chronic conditions that our patients have at the same time, being comorbid, and moving in towards what we now refer to often as population health management. As we look at population health management and we think about the health outcomes for a group of individuals, including the distribution of such outcomes within that group, we also have to realize that those populations can be multiple types of identification. Yes, they can be senior population, they can be a chronic care population, they could be a specific cultural type of population, and physicians and primary care specialists have populations also that they address within their practice. So if we look at it through a population health improvement model, which has been supported through Population Health Institute, we would look at three components: that central care delivery and leadership roles for that primary care physician that addresses that critical importance of the patient activation and involvement and personal responsibility, which is absolutely key in developing those strengths, and the patient focus and capacity for expansion of care coordination provided through wellness, disease, and chronic care management. And then as we look at that last definition for external and independent review during the development of our IROs and the ability to look at reviews that were not associated with the utilization management or utilization review process and have an independent assessment of that. They shouldn't stand alone, what we're talking about here. They are combined in this role of care coordination. And today we see terms like transitions of care and care management and all the various support around the patient-centered delivery models. And together, these particular interventions will help us deliver care coordination and improve that experience for the patient through the continuum. Let's take a little bit of a look on our next slide about just its development and history over the years as we put this all together. We call it the medical management evolution, but it really began in the early 1900s. It began as we were looking at some of the case management programs that were delivered for the poor economic groups and for in World War I and II as we came forward, those soldiers that were returning with specific injuries and the need for care coordination. Utilization management began to really gain and be talked about in 1973 with the Federal HMO Act was adopted. And about that same time as Medicare came in and we started looking at these various roles and processes, it began to really drive the evolution of being able to provide those services. As you can see, through each of these years, there were different processes and laws and regulations, as Bob said, that continue to grow in this area of utilization review. We also saw it move into workers' comp in 1995 with accreditation standards, and URAC took that first step with also having its reviews in 1989 as it began this whole process of adopting that. Case management standards with URAC came in 1999, and each one of them, as we moved into 2000, had greater guidance and focus. Utilization management also fell under a different determination in 2011 and 12 in the Affordable Care Act, when the medical loss ratio was also redefined as to what was quality and what was administrative. As we're moving forward, will play a very important part as we are looking at mental health parity, and in 15 as it's becoming active in its implementation. The Affordable Care Act also brings that into alignment with helping with that care coordination and the processes that we need to do. As I turn this over to Gary, who's going to be going over some of the survey, I will be back later in the presentation and talk a little bit about how I see this all coming together in the future. And I think that has a very important role and needs and has great opportunities to look at how they can use the years of experience that they've been developing this process to even greater support of both patients, family caregivers, and providers. Gary?
Thank you, Sherry. Great introduction and very informative. First, I want to thank Epstein, Becker, and Green and EBG Advisors for helping fund and sponsor this webinar today, and also the survey work that underpins what we'll be reporting on utilization management regulatory trends. I also want to tip my hat to Sherry Latimer, who has been my partner in crime over the years in terms of dealing with different public policy issues impacting the medical management system, and I always reach out to her for a reality check, so she's an invaluable resource. You know, it's funny, there's an old saying that life is 1 degree of separation. Throughout my career, utilization management has popped up in many different ways and forms. When I first entered into legal practice, I actually was a junior associate at Epstein, Becker, and Green, and the floor below me, I didn't know it at the time, but URAC was being incubated in 1988, 1989. And then I obviously became a little bit of a managed care attorney and worked for the old Group Health Association of America. But not too later, in the 1993-94 timeframe, became legislative counsel to the National Association of Insurance Commissioners. And among other things, it was there that I helped draft the Model Utilization Management Model Act, along with the Grievance Procedure Model Act, and then eventually migrated over to the head of URAC, where, you know, during my 9-year tenure, we revised the utilization management standards 3 times. I thought I escaped utilization management, at least over the past 10 years, but to my good fortune, the Kennedy Forum engaged me to help them on some of their policy initiatives, particularly related to mental health parity, which has given me the opportunity over the past 6-9 months to really think about the medical management system again. So the old saying, life is 1 degree of separation, is true when it comes to utilization management. We have a lot of ground to cover, so I'll go ahead and move briskly through the slides. You know, as Sherry's described, you know, we're talking about utilization management today in terms of the regulations, but there's a much broader storyline. One of the things that I did at URAC with my colleagues there to try to make sure we're coming up with the very best standards was try to understand the regulatory trends, constructs, et cetera, as we were either creating a new accreditation program or an updating an existing one. So to that end, the work today of the regulatory update for is really kind of the 4th edition, if you will. In 1999, 2001, and 2005, URAC led the initiative and published 3 publications on trends. So this represents, to the best of my knowledge, the first update in 10 years. Now, of course, life changes, technology grows, so the emerging version that will be reported will be not on a paper manual, but on an online regulatory tool, which we'll talk about a little bit later, called RegQuest. So the work, obviously, that's being reported today and will be, you know, it's available online, and there'll be actually a report that'll be published later this summer builds upon the previous work that was done with the previous surveys, but also includes a refresh with some new templates and things like that. One of the things that we try to do in this regulatory research is to summarize the laws and regulations on any particular topic in kind of actionable buckets, and you'll hear more about that today. So obviously this involves in-depth legal research, and part of what we try to do is get the state regulator themselves to peer review what we report. So for this time around, for the 2015 regulations, for example, 2/3 of the states have weighed in and peer reviewed our findings, and that work will continue. We also, I think one of the big things to note is that obviously the Affordable Care Act has impacted a lot of what we're covering today, and certain states such as West Virginia have really updated their laws and regulations, state laws, to come into compliance with the federal standards. The scope of the survey that we're reporting today covers the 50 states, the District of Columbia, and 4 state territories, American Samoa, Guam, Puerto Rico, and the Virgin Islands. So there's a total of 55 jurisdictions that we're reporting on. And so when I get later into the summary, when I refer to the X amount of states, I am referring both to the states and territories that may be regulating an aspect of What the survey doesn't cover today, but we will be adding, is some of the federal requirements, such as the 2002 Department of Labor Claims Procedure Regulations, the 2008 Mental Health Parity and Addiction Equity Act of 2008, and I have some comments on that later, and the final rules that mostly address external review processes, but also internal claims that were published in the summer of 2010. This initial survey report also does not include some of the specialty regulations such as worker comp drug utilization review, and specific Medicaid requirements. And it also doesn't include accreditation standards. Next slide. So, there's a storyline here. We're talking about utilization management, but we would be not given the full story if we didn't talk about the larger medical management system. There's issues about, what's the regulatory interfaces between the different functions within managed care that Sherry's alluded to. There's the issue of risk management. How, if you're working for a health plan or you're a regulator, how do you actually make sure that the laws are being, implemented properly? And then there's the issue of consumer empowerment. How do, patients and others, actually take advantage of the resources that the laws afford? The medical management surveys through RegQuest are first going to obviously focus on utilization management, and then not too far behind that we have external review, which will be published early fall. And I think that's the first time there's been a comprehensive 50-state survey on that issue. We'll also be working on grievance procedure and administrative requirements. The Kennedy Forum through the Scattergood Foundation is updating the state mental health parity laws as well, and then we're hoping to do something on case management down the line. So, when we look at this all together and how it interfaces, there are some key public policy issues at play that we need to work through. Next slide. This is actually a table that was produced in the 2005 edition of the Guide, which I put together, and it just serves as a proxy to say one issue is that there's a large volume of laws and regulations, and as managed care and healthcare has become more complex, in some respects there's more regulatory challenges, but also gaps that emerge just because of the complexity of how healthcare is provided. But suffice to say that there are thousands of state laws and federal regulations that address some of these core functions that Sherry just referenced. Next slide. So one of the things in terms of getting into the buckets that the Utilization Management Survey covered are these kind of 6 basic areas. First, what's the scope and applicability of the laws and regulations? Who's the primary regulatory contact person for that particular jurisdiction? does the state, in fact, have specific registration or licensure requirements for that state? What are the specific program requirements? What are the reviewer qualifications? And what is the appeals process? Now, what's interesting is that, you know, these are mostly kind of process measures in the basic buckets, and they do have a lot of variances in the states. A historical footnote, when the NAIC finally did adopt the Model UM law, which was around 1994, I think at least half the states have already adopted their own state UM enabling legislation, starting with Maryland in 1988. So in some respects, the NAIC and the opportunity for standardization kind of missed the boat. URAC was out of the gate with its first set of standards either in 1989 or 1990, so they were able to provide some standardization. But when we get down to the details, you'll see actually a fair amount of variability in some of what the different states do, which is its own kind of public policy issue and challenge. Obviously, with the federal regulations, that establishes a floor if those federal regulations are applicable. Next slide. You know, there are a lot of trends which Sherry alluded to. So obviously you have kind of these ebbs and flows. You know, Bob mentioned that, you know, some people were saying that UM may be fading away, and it really is stuck around and you know, does have a proper role when used correctly, but you have the rise of population management, complex condition management, this move towards integration. You know, you have the Affordable Care Act, which has, you know, a lot of, if you will, mandated benefits, which puts pressures on payers to make sure that they're allocating care in a proper way. You have the federal mental health parity law, which is leveling the playing field between med-surg, mainstream medicine, and behavioral health, you know, mental and addiction services, which is extremely important. You have kind of feedback loops over the years about when is it, at first, you know, there was, everything was pre-certified, and now there's kind of more of a high-touch approach to UM, really where can utilization management make a difference. There's obviously, with the movement emerging over the past, you know, 5 to 10 years on value-based purchasing, so there's going to be much more focus going forward, I believe, just not on process measures, but actually what are the activities that produce improved clinical and financial outcomes. And as I just referenced, there's a lack of standardization. And, you know, because of this complexity, regulation is limited. And I think with the move towards high deductible plans and things like that, we're going to be hearing more from the consumers. Next slide, please. So let's dive into the regulations. As I said, there are 55 states and territories that the survey covered. 46 of those jurisdictions regulate UM functions directly in some capacity. Of that number, 47 of the 50 states regulate utilization management. Those states that do not regulate utilization management is Florida, Utah, and Wisconsin. Probably one of the more biggest changes since the 2005 survey is the fact that Florida repealed their utilization management statute. The District of Columbia also does not regulate utilization management directly, and 3 territories do not: America Samoa, Guam, Virgin Islands. So in other words, Puerto Rico does. So you can see here that when of those 46 jurisdictions, most of them do tag the major kind of health plan type entities and the utilization review organizations, and a lot of times it's framed as the utilization review agent, but has implications back to the organization and then third-party administrators. So in the majority of those states, those entities are regulated. There are some emerging type of corporate entities like accountable care organizations, which we track, but that's really, you know, kicks in only when that entity is licensed in the state, even though they may not use that term. And then, you know, it's interesting, Sherry had reference to the different types of utilization management. You have, you know, prospective, concurrent, retrospective. There are different names that are used. So approximately 30% of the states, or 18 states out of the 46 jurisdictions, actually specifically reference that type of UM, which may have some, you know, specific conditions to it. And then at least 37 out of the 46 states had at least one exemption where the UM law was excluded. Next slide. Now, in terms of actually licensure, 34 out of the 46 jurisdictions that regulate or 34 out of the 55 jurisdictions, actually have specific licensing criteria. We did not include like North Carolina, which just has a simple filing requirement where they provide a report each year. But as you can see in those 34 states, there's a renewal period. About half of them are annual, half of them are biannual, and then 2 require triannual filings and licensure, and then 2 didn't specify it. And then likewise, you can see 28 out of the 34 states actually have a licensure fee of some sort. 13, it's fairly moderate, under $500. 12 states have between $1,000 and $1,500, and then 3 states have $1,500. And about 4 states have reduced or waived fees if you're URAC accredited. Next slide. This is kind of the meat of a lot of the program criteria, so you can read the different functions here. The regulations from a workflow and process perspective will regulate key components of the program. The clinical review process, 44 states out of the 46. Prohibition against financial incentives, 29 out of the 46 states. And if you recall, really one of the first waves of regulation in the 1980s, early 1990s was the fact that there were some financial bonus payments for reduction of care that just weren't palatable from a public policy perspective, so the regulations quickly prohibited those types of transactions. 39 states have some sort of telephonic coverage requirement to make sure a consumer or ordering provider can actually make contact with the person that's in charge of approving the quality control assurance or quality program, that was something that grew more in the 1990s. Delegated oversight, a lot of, obviously health plans and other entities delegate parts of their functions, so 28 states have specific provisions. 43 out of the 46 states have specific review requirements, and obviously that's a big deal to make sure you have the right clinician at the right time making review, whether it's the initial determination or through the appeals process. 20 of the 46 states require a medical director, although I think that's implied probably in many of the other states. And then there are requirements that those medical directors or physicians be licensed in the state where the transaction is taking place for the patient, 23 states. And interesting enough, this is an issue that URAC has dealt with for some time, as some of the functions were moved offshore, but 0 states actually had provisions that we could find dealing with offshore functions, and that kind of symbolizes the fact that that does happen with some regularity now. But once the regulations are kind of established, it's sometimes hard for states to stay updated with current trends. Next slide, please. So this kind of talks a little bit about the states in terms of the number of appeals. If there's an adverse determination, and the patient or the ordering provider wants to question that determination, you can see that the box on the left has 20 states have 1 to 3 levels of appeal, mostly 2 levels of appeal out of the 55 jurisdictions, and 35 have no provision. And then the time frame for the initial determination, you can see that 16 states specify a particular time frame, 39 do not. And it's interesting to see the variability in terms of different time frames. Of course, one confounding variable there would be actually whether it's prospective, concurrent, or retrospective. That's got to obviously influence some of these time frames. Next slide. This actually talks a little bit about some of the time frames regarding the standard appeal process and the expedited appeal. So similarly, you can see out of the 46 states that regulate utilization management, 44 jurisdictions have designated a time frame that denotes when a standard appeal can take place. And again, a confounding variable would be whether it's prospective, or concurrent, or retrospective. And then you'll see that in terms of expedited appeal, the box on the right, that 37 states designate a time frame. For obvious reasons, those time frames are a lot shorter. And then in the middle, you have just basically different requirements in terms of appeal provisions. So for the first 3, 46 of the 37 states actually require notice of appeal rights. 7 offer extension options, and 38 specify what should be in the final notification provision, which usually is a queue for the next external review process. And then finally, 49 out of the 55 states have external review provision, and there will be a module on that offered again later this fall, which will go into greater detail with that. Next slide, please. So, you know, it's funny, this is a sample appeal policy. I have to admit that I drafted this for an organization. I worked for a private sector ACO after I left URAC, and it kind of, you don't need to know the details, but shows some of the pathways of an internal appeals process based on expedited standard and prospective, concurrent, and retrospective, and I tried to marry up. This entity was, you know, trying to comply with state laws, the federal requirements, and then was planning at the time to get URAC accredited, which eventually did. And this just kind of reminded me, in the 2005 guide, you know, there was a number of challenges and open-ended issues that still needed to be addressed. There's a list of 14 or 15 of them. And when I reread them in preparation for the webinar today, it kind of reminded me that a lot of these are still real issues. You know, what is the ROI on interventions? Is the decision to deny care a medical necessity or benefit determination? When is the delay in the process effectively a denial? How should clinical guidelines be used within the process? Is the patient or provider aware of their appeal rights? You know, the questions go on, and so I think as part of this, we're still, as a society, working through some of those fundamental issues. Next slide. Obviously, what's happened since 2005 is we have had the Affordable Care Act. We've had kind of the locking in of additional appeals requirements. We have the appeals process, which involves the internal process and external. We have the kind of administrative grievance procedures. You know, if it's a benefit denial or a payment issue, it may likely fall under that bucket. You have the Mental Health Parity Act adopt that creates additional layer of appeal for when there's a perceived or real violation of a mental health coverage issue. And then, as I alluded to, you have a kind of a wave of external appeal options, external review appeals, regulatory complaints, accreditation audits, arbitration hearings, judicial hearings. And one of the things that's happening now is that really the consumer legal advocate community is really beginning to spotlight some of the shortcomings of the current appeal system and how convoluted it is. And I think one of our obligations is to try to see if we can kind of navigate and create kind of connection points between the different regulations to make sure there's a functional appeals process. And you can see that examples of, if there's a parity violation, making sure that there's, or even a adverse determination, what's the proper disclosure of the review criteria that was used. So in other words, there's just a general pressure point of increased transparency and accountability. Next slide, please. So, next slide. So I think just real quickly, I'm going to run through the next couple slides so we can get back to Sherry talking about the future of I think the thing to keep in mind is that there are a lot of different types of insurance types offerings that are going to impact what regulations kick in for a transaction, whether it's commercial insurance, typically regulated by the Departments of Insurance, whether it's under a group or non-group policy. Then you have self-funded plans, government plans, military plans, union plans, and different, Medicare, Medicaid requirements. Next slide. And that kind of feeds into different types of regulatory agencies that need to work together, both at the federal and state level. And that opens up kind of the door for the notion of federalism and how preemption works. I was just on a call earlier this morning where we're talking about the fact that the federal mental health parity bill, authorizes states to oversee key provisions of that law, yet some states have not authorized their state regulators to actually carry out that, ask from the federal government. So there's all this kind of give and take between the different layers of government. Next slide, please. And then you have just really kind of, in addition to the federal and state levels and statutes and regulations, you have other types of regulatory guidance that come through agency bulletins, Attorney General opinions, obviously common law, and so on. One of the examples with utilization management that the laws don't really address is, whether it's assumed that utilization management is not the practice of medicine, but early on you had a lot of the state medical advisory boards saying yes it was, and then as a counter to that you had 5 or 6 state attorneys issue opinions saying no it's not. So that's just an example where some of the additional details can play out at this sub-level. Next slide. And then also just keeping in mind that you have different governing factors and ultimately how that impacts how the care is provided. You have the regulatory layer, you have the plan documents, you have the payer policies, and geographic locations. I mean, the Dartmouth Atlas studies is a good example of that. Next slide. I think one of the reasons why utilization management is coming back in front and center is that with the adoption of the Mental Health Parity and Addiction Equity Act of 2008, MAPIA, and now the regulations have been issued and they're now full force, that's creating a lot of public policy discussion about really how do you compare a med-surg care versus a mental health provision of care. And there's some technical terms we don't have time to get into today, but there's the quantitative treatment limitations, which is more kind of a financial apples-to-apples comparison, and then the non-quantitative treatment limitations, testing and disclosure, which gets much more down to kind of a medical necessity determination. So as we kind of work through that as a society and try to shore up kind of new testing protocols and new ways to cover care or, basically say that this care is not authorized, that's kind of reopening up the utilization management system. And in fact, in some cases, some states will have kind of a parity appeals process that's embedded that's pretty straightforward, and then others will back into it through the utilization management appeal system. I've been fortunate to work with the Kennedy Forum to work on 5 public policy pillars. The first one is payer accountability, which this kind of falls into in terms of how you come up with a more system and standardized approach to making sure that there is a level playing field. But also, which is exciting to me, is that this talks about kind of the larger integration of, traditional areas in the healthcare system have been fragmented, that being, behavioral health care services into mainstream medicine. Next slide. One resource I wanted to point out to the group is the Parity Resource Guide, which was just published in June. That was a partnership between the Parity Implementation Coalition and the Kennedy Forum. It's about 100 pages. You can download that for free at either the www.thekennedyforum.org website or the Parity Implementation Coalition website. And it really provides a very, very nice overview of some of the specifics related to mental health parity, but also the general medical management system. So with that, I'll turn it back over to Sherry for some additional comments about the future of
Thanks, Gary, and thanks for that great overview. I think that all of us, as we look at where does play in this, need to couch this within the functions of the triple aim. As we said, was focused on the responsibility of balancing that quality, that risk, and that cost concern. So it truly is focused on the better health, better care, and lower cost. But what does that mean, and where are the areas that we focus? Well, the first area we want to focus on is the high cost and those high risk issues, procedures, and care that our patients and their family caregivers are often traveling through and navigating through. As we look at that and we look at both at the hospital level and we look at what's happening at the hospital readmission and the penalties, can actually focus it not only on its admission length of stay, but a heavier focus on its care coordination at that discharge transition summary place, utilizing what we've learned over all these years around the key interventions that are most necessary at that transition discharge process to ensure that an unplanned readmission has the best chance of not occurring. Did the patient get a care plan? Was it written so that it was in a health literacy, that the patient and the family caregiver understood what was being asked of them and that they are confident that they're going to be able to achieve that when they go home? If medications have been changed, have been added to, have had a whole new regime, did we actually see the pharmacist and the case manager with the team utilizing the ability to advocate, to actually do medication management therapy, and to encourage that that medication list is also in the hands of the patient and the family caregiver, and that there was a teach back through that? Have we followed through that if there's follow-up tests, that those are going to occur? Tying in more than just the review criteria of the moment to the care coordination of this patient throughout the continuum of care. It's also going to be focused around the specialty pharmacy and high-risk medications. Again, incorporating that review from, did the patient get their preferences and their thoughts included in this process? Were they given the ability to ascertain and make some decisions with the team and with the physician and the pharmacist about other options or the process of what that is? Do they understand the ramifications of those medications and being able to understand the refill process and what they need to do? We can't just check these off that there was a discussion. Did it really sink in? Was there good recall from the patient and with the provider and good comprehension of what needs? So moving it to that care coordination, to that focus that we're looking at. As Gary said, we're going to look at the mental health parity through the eyes of not only case management, but utilization management, which would be our next level of what is that future that it would be applied to. In that process of being able to help understand where we are in applying both formulary issues of medications, chronic conditions, and being able to manage it the same way we do with our medical process. If you could just click on that slide, I think that brings up that key point of mental health parity. And the last thing I think that has a great future to really look at is, we know that as PCORI is developing patient-centered outcomes, they are looking more and more at the shared decision-making that patients and their physicians make together with the collaborative team, being able to be informed. We know that at the hospital, from discharge from the hospital, patients are being asked the three questions that come with the care transition measures, the CTM3. Were my preferences taken into consideration? Do I understand my medications, and am I able to understand what's being asked of me when I go home? The process of being able to also tie that in when we do that discharge planning review, we do that process, is going to be really key and is a help to the team. As we move to the next slide, I really want to talk about what that team is. As we click on this piece, I want to talk about having a collaborative practice framework for how is part of this care coordination in this affordable care and restructuring of our healthcare reform, and how everything that we've learned over this process can really be built in being able to change this not only from medical necessity, length of stay, and these various aspects that Gary talked about, but expanding it into this care coordination model that becomes part of the team with the physician and the pharmacist and the advanced practice, the nurse, the case manager, and the social worker, and that in utilizing those services and sharing that with that patient and caregiver in the middle, the triple aim can actually be achieved. And to go beyond that, from collaborative to that patient-centered process and that direction and preference. And that has to be shared with the community. Wherever we are in this process, whether at the acute care hospital setting, in a patient-centered medical home, an accountable care organization, in a skilled nursing facility, all of these things cannot just be focused at that level of care. The future is the sharing across the continuum of care. As you know, we are working with meaningful use and many other documents to try and reduce the documentation nightmare that we have and to be able to share information back and forth. We are still struggling with many of the silos and fragmentations that we have, but the ability to really see this as this care coordination and the ability to do what this was focused on, which is balancing the quality, the risk, and we say the cost concerns, but let's put in balancing the patient's experience within this system also. Wouldn't it be wonderful if we never hear again that utilization management is the mother may I or the hell no line, but that is the lifeline of care coordination, helping people make decisions based on experience, criteria, appropriate level at the appropriate time, and helping this collaborative team with our nurses, our social workers, case managers, physicians, pharmacists, advanced practice, and our allied health being able to work together in transitioning patients through this process to the best quality experience that's possible. I think those are great opportunities. I think they're exciting times that we can move forward with, and I hope that we see that this isn't a standalone. This is something that has to be incorporated and integrated into our full care coordination, and it is a very, very useful intervention.
Thanks, Sherry. You know, as we kind of wrap up, and I just give you a quick review of what RegQuest is going to do, you know, there's so many different flavors of utilization management. You have utilization management programs that are still run very much on a standalone basis that are geared towards specialty services. You have utilization management that's fully embedded and into complex condition management and integrated framework. And, you know, no matter what, when it comes to deciding whether through the payer function or the actual clinician, what's the medically necessary and appropriate care that I deserve as a patient, that gets to the heart of what we're all doing. You know, all of us here on the phone today are healthcare professionals. We may be, you know, we may work for a health plan, we may be a regulator, we may be a lawyer, we may be a researcher, we may be a consumer advocate, but nonetheless, we're all called to this altruistic, you know, goal of really trying to improve the healthcare, or we would have picked an easier career for sure, because healthcare is certainly not static. When you look at trying to inform public policy decisions, unfortunately or fortunately, you need to have a proxy of what the regulatory world is out there. It's not glamorous. You know, you also need to look at, as you know, Sherry's been sharing with us, some of the actual practices that are already going on there. You need to study enforcement actions to see what's being enforced and what's not being enforced. And by then, we can have a community that talks about making better decisions. And a lot of this isn't easy. A lot of this demands a fair amount of technical proficiency. So RegQuest was built to kind of offer a basic interactive dynamic environment to begin to at least understand the regulatory constructs out there that impact the medical management system, and will probably be expanded over time. So instead of a book that's published once every 10 years, you have an online resource tool that's published or updated, you know, as soon as we hear word that something's changed in the state. We try to maintain things in actionable buckets. We try to get the regulators involved and peer review what we're doing. We're trying to provide this not only in kind of a page format, which is PDF format, which will look like a book, but also HTML, if that's your preferred way to read the information. You know, it's obviously divided up into kind of the different state buckets as well. We will also add different issue briefs and updates that will make it timely with trends going on. And then we've tried to come up with other things in terms of summary tables so you can quickly look to the different you know, trends without having to listen to a webinar like this with the PowerPoints. There's actually some very nice summary buckets. Next slide. So the navigational elements of this are pretty straightforward, whether you need to look at something at a national level or a particular jurisdiction or jurisdictions in terms of how you navigate through this. This is a subscription service, and so there's an online annual fee. There are discount programs in place, and then, for example, regulators offer complimentary access to the service. Next page. And, you know, it really does kind of provide a fair amount of detail with live hyperlinks back to the actual state statutes or regulations that it's referencing in terms of the details for a particular jurisdiction. If you want to learn more about RegQuest, you can fill out the contact form, which is at www.regquest.com, or you can call 443-808-0818. 443-808-0818. Now, one of the things that this site will do is work with EVG advisors, the Case Management Society of America, the Kennedy Forum, and where we can publish information for free on a complimentary basis, we'll do that. When we get to, for example, the regulatory summary, there'll be a public version that's free that goes into a little bit more detail of what I described today, and then there will be the very detailed summary that a risk manager will want. So we're excited that we kind of moved into the 20th century in terms of keeping this updated, and please feel free to reach out to us, and if you have any feedback on any of the survey information or have some ideas, please chat with us. So with that, I'll turn it over back to Bob for Q&A.
Thanks, Gary. I think you meant the 21st century there, but not the 20th.
Thank you.
We've got about 5 minutes till we log off, and there's been on the chat in the chat area we can take questions. We won't be doing questions audibly. A couple have come in. Well, actually, there's been one active commenter during the presentation. Somebody who knows the history of UR and UM, and we appreciate that. One of the points that this individual mentioned is, that the original provisions of the Social Security Act that created Medicare and Medicaid required hospitals to have utilization review committees and introduced the PSROs, the Professional Standards Review Organizations, which, I guess that person and I are probably the same age, because my first job out of graduate school was in the federal agency that oversaw the PSRO program. So you're right, but probably most of the people who are on here today don't know that. They might know about PROs and the more recent use of the term QIO and so forth. So that whole thing has been evolving along with it. We do have one question that came in during the presentation, which I'm going to see if Gary or Sherry can answer it, but it was about, are there specific requirements in Kansas? And if we can't answer it immediately on an impromptu basis, we will follow up with the questioner and get you some input. Gary or Sherry, you have any intimate knowledge of the state of Kansas regulation of UM, UR?
Kansas?
Yeah.
Yeah, the state of Kansas?
Yep, you bet.
Yes. The state of Kansas does have UM regulations, and it does require licensure and certification, and it does have provisions that address most of the buckets that I described today.
Okay. Couple other questions. First of all, I'll just mention that within 2 to 3 business days after today, the webinar slides and the recording will be available to all registrants. And somebody asked how much is the survey. I assume that means the subscription, the annual subscription fee for RegQuest. Do you know that, Gary, offhand?
Yeah, the retail price, I believe, is $595 for an annual subscription, which gives you full access to the updated utilization management modules. And then with each additional module, there'll be, some additional pricing set for that, and then some sort of discounting. There are some groups, such as if you're a client of Epstein, Becker & Green, you'll get a discount off that retail price. So it's important for that person to call into the RegQuest line to get the specific pricing that would apply to them.
Okay. Another question that came in is, can you comment upon what you believe are the ramifications of the Univita events in Florida? I'm afraid I don't know that. So, anybody? Sherry or Gary?
No, I can't respond.
All right. Well, if the questioner can maybe send me an email, my email address is up on the screen, and I'll see if I can't follow up. And we do have a large staff here at EBG Advisors and Epstein, Becker, Green who know a lot about what's going on in the industry, so I probably can get the answer within a few minutes of receiving your email. Generally, I guess, let me just throw in one more question about, what's going on. Is there a resource listing for regulators in each state? Is that something that's in the RegQuest tool, or is that another?
Yes, the regulatory contacts are in RegQuest with a fair amount of detail. A general listing is also as part of the Parity Resource Guide, which you can download from the Kennedy Forum website.
All right, great. Well, our time is up. I want to thank Sherry Latimer and Gary Carneal for an excellent and informative presentation. We're also seeing a number of compliments on the screen from people entering those in the chat, so thank you for that. We've had a good number of people hanging in for the whole hour and really appreciate your participation. So look forward to the next in the series of webinars coming out of EBG Advisors on population health. Thank you again, and see you soon.
Thank you for joining us. This concludes today's webinar. In approximately 2 to 3 business days following the webinar, Epstein, Becker, Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We hope you join us for our upcoming webinars. For additional details, to register for an upcoming webinar, or to find recordings of prior webinars, please visit www.ebgadvisors.com. Our next Population Health webinar is on September 21st, and it will cover topics of relevance to safety net healthcare providers. Thank you.